Basically, they said anything that was non-emergent needed to be suspended. And this was issued 3 times over the course of the pandemic. And what we're probably looking at when we look at these figures is an underrepresentation of what is actually truly happening. Its designation as a vaccine allowed it to circumvent the regulatory controls that are normally put in place for gene therapy. I think that this is probably one of the greatest health rights violations that I've seen. Only a fraction of the beds that were actually put aside for COVID-19 were actually used. What we see both from the billing data and also from the confirmed cases, a similar pattern where we see a drop in 2020 and then continuing rises in 2021 and 2022. By suspending it for that first lockdown, what they did is they created backlogs in care that are continuing even to today.
Well, we're gifted to have one more speaker today, another hero of the COVID war from my part of Turtle Island and the northern half of North America. And that's Deanna McLeod, who is the principal and founder of Kaleidoscope Strategic, an independent medical research firm that supports Canadian clinicians in preparing world-class evidence-based reviews that advance patient care nationally and internationally. Translation, she is a master of coalescing large amounts of research, putting it together and looking for practical solutions that can lead clinical work. The Kaleidoscope team brings a collective over 40 years experience in developing evidence-based peer-reviewed publications that guide cancer care, alongside decades of experience working with medical research, marketing, sales arms of pharma. So Deanna really has an eye into a lot of things that are related to this. In March of 2021, Deanna launched COVID Sense. Thank you for that. You saved many lives. And that was an initiative to equip non-scientists with the skills to interpret COVID data and make informed consents. Later that year, she joined the Canadian COVID Care Alliance, which of course is an amazing Canadian independent association of doctors and scientists that stood up against the mis and disinformation. So with no further ado, I would like to bring forth really an expert in clinical data and analysis, Deanna McLeod, and looking forward to what you have to share today.
Thank you, Mark. Appreciate it. I see my slides there. Oh, there we go. So I'm coming here today to chat about an initiative that we've undertaken in collaboration with Canadian Citizens Care Alliance, the We Can Do Better campaign. And I just want to thank all of the previous speakers for their amazing contributions to the discovery of the rise of cancer following COVID-19 vaccination. And this is a little bit of our journey in bringing this information to actual treating medical oncologists in Canada, and documenting the discoveries as we dug into administrative and medical databases in Ontario to try and find some answers as to what is happening. So this We Can Do Better campaign is on the Canadian Citizens Care Alliance website. And we also have wecandobettertogether.org if you want to find out more information about this. We've written a 37-page white paper, which has all the references that you can imagine in terms of documenting what I'm going to be presenting to you today. So I think we've already had the introduction. So right into our publication. So in May 2025, we published our findings on changes in female cancer diagnostic billing codes from the Ontario Health Insurance Plan database. And what we saw was overall a decrease in cancer diagnosis in 2020, and then a concerning rise in cancer billings related to female cancers in 2021 and 2022. And so this is our pinned tweet on COVID Sense, and it's basically had 92,000 views at this point, and we're really hoping that with more views we can really get this information out there. We particularly focused on female cancers because one of the things that we noticed when we were looking over various databases was that there were more side effects following COVID-19 vaccination in women than men, which is something that's very unusual. And so what we wanted to do was we wanted to find answers. And so we thought if we could harvest data from OHIP, which is represents 16 million residents in Ontario, which is a very large province in Canada, we could really gain some insights into what's actually happening and to see if we can document any changes in cancer rates, incidence, etc., from this. And so, unfortunately, one of the problems with data harvesting in Ontario or in Canada are that quality data takes time to come to fruition. So administrative data is fairly timely, although some would argue is less reliable. And one of the things that has to be considered when you're looking at diagnostic data or billing data is that the diagnostic code that's assigned to the visit. So if a physician goes to visit, if a patient has a cancer concern, a woman has a cancer concern, she visits her doctor, potentially about abnormal bleeding, potentially about a lump. Basically, that doctor, if they suspect that it's cancer, would assign a diagnostic code of invasive breast cancer to that. They could assign a number of other codes, but it is very possible that they could assign a breast cancer diagnosis on the first visit. So when we're looking at the administrative data or the billing data, what we're looking at is data that is very early in the diagnostic pathway. So it probably includes suspected cancers, and therefore it probably overrepresents the number of true cancers. And then Ontario Cancer Statistics is basically data that's accumulated based on the final visit. So once they've confirmed that it is in fact a cancer diagnosis, then they would assign a code there. And so what we wanted to do was we first looked at OHIP because that was the data that was available first. And then we moved to Ontario Cancer Statistics and looked at data there. And so the data that I'll be presenting to you is OHIP on the left and Ontario Cancer Statistics on the right. So here is the diagnostic billing these are the results for female cancer, so cervical cancer. On the left, what you can see is a linear regression analysis where we take data from 2015 to 2019 and we project out what we would expect to see over the COVID period. And so in 2020, we see a drop in billings for cervical cancer, which is beyond the confidence intervals, so probably not by chance. And then in 2021, we see almost an equal and opposite increase. And then in 2022, we see a continued increase in billing codes for cervical cancer. On the right, you can see actual new cases of cancer for cervical cancer. And so you see that the line has a similar slope. It's continuing up. There's a drop down in and around 2020. And then again, the 2021 and the increase in 2022. So what we see both from the billing data and also from the confirmed cases, a similar pattern where we see a drop in 2020 and then continuing rises in 2021 and 2022. Now we look at breast cancer. You can see that the historical line is going down. And in 2020, you don't see the same drop in billing rates for breast cancer. And that's because there were a lot of initiatives put in place in Cancer Care Ontario to try and maintain screening for breast cancer over the COVID period, unlike many other cancers. But surprisingly, again, what you do see in 2021 and 2022 is this continued increase, which is beyond the likelihood of chance. On the right-hand side, you see a drop, that maybe a rise in new cancers, a slight trend upward, and then a dramatic drop in 2020, and then an increase again in 2021 and 2022. Uterine cancer, again, similar to breast cancer on the left, billing codes basically continued according to trend lines, and then an increase in 2021 and 2022, similar pattern on the right with confirmed cancers. And then ovarian cancer, you have the drop, the increase, and then the approaching trend line. But on the right-hand side, you can see that the trend line is going straight up in 2022. So unfortunately, the nature of the data is that we have this snapshot of what is happening between 2015 and 2022. We've ordered the data for up to the end of 2024, and we should be receiving it momentarily. But what we can definitely note when we look at some of these slides, especially cervical cancer, is that there's something that's going on, and there's a continued rise in cancer rates. And the other thing too that we need to remember is that you'll identify increases earlier when you're looking at administrative data, and they'll only show up a little bit later whenever you're looking at actual registry data. And that's because one of the things that occurred during the COVID pandemic, and I want to speak to this drop right here, is that cancer care was in fact suspended for the first lockdown. So even though cancer is 6 times more deadly than COVID, which is all the way down here, what we had was our public health officials, who were the designated quarterbacks for the pandemic, suspending non-emergent care, so anything that was an emergency. And basically that included all of the screening for breast cancer, the imaging, the biopsies, and everything. And so by suspending it for that first lockdown, what they did is they created backlogs in care that are continuing even to today. So that we have backlogs in detection and diagnosis, which means that even if we wanted to know the magnitude of the effect of, say, for instance, vaccination, we're probably getting an underrepresentation of what we're expecting because this non-emergent care was suspended. So for screening, this was when we actually looked at it, what we found was that there was a directive 2 that was sent out to all hospitals and physicians. And basically they said that anything that was non-emergent needed to be suspended. And this was issued 3 times over the course of the pandemic. And we have some great epidemiologists who've looked at what happened to cancer care during that time, during that especially in the 2020 period, that first lockdown. And we have 650,000 some female screenings that were missed. We have about 3,000 fewer cancer surgeries during that time, or 8,000 fewer cancer surgeries, so P2 and P4 surgeries during that time. So almost every aspect of cancer care was basically suspended. And so one of the things that we're looking into is the ethical and legal basis, whether that was actually appropriate. Because in Canada and in Ontario, you are guaranteed health services despite disability, which would be cancer, and also gender, which would be female. And so when the Directive 2 was initiated, what we found was that female visits to primary care physicians were deterred. And to diagnose female cancers, what we actually have to do is there's a cytological test for cervical cancer that needs to be done. And of course, that's with the primary care physician most often, is also a colposcopy. So especially things like cervical cancer, what we're probably looking at when we look at these figures is an underrepresentation of what is actually truly happening. And here, because there's such delays in actual diagnosis, because diagnostic capacities were suspended for almost a year, what we're probably going to see is when we look at the 23-24 data, we very well may see this continuation of the trajectory that we're seeing in the administrative data. So in terms of is there an increase in female cancers? I think that the answer would be yes. We do see net increases when you look at excess billing incidents and also excess age-adjusted mortality or incidents, which is the right-hand side. And so the question that we have as well was there a stage migration? So stage migration, as has been mentioned before, means that the cancer is presenting at a later stage than expected. And so when we look at the data here, we see that there's fewer breast cancers, and these are screened cancers. We have data for this. But basically, we have fewer breast and cervical cancers presenting in stage 1, which is when we want to find them at early cancers. And we have them presenting at later stages, particularly stage 2 for cervical cancers and even later for some of the cancers. And even though the numbers are relatively small for breast cancer, because there's so many breast cancer patients, these numbers are pretty significant in terms of clinical impact. We also have a study here that was done where we can see the number of stage 1 cancers, breast cancers that were normally detected when we're looking at, pre-COVID era in the 2019. And you can see that there's very few stage 4 cancers at presentation. And here what we see is more stage later stage. I can't speak to whether this is turbo cancer or whether these are basically cancer left growing in the bodies of women for longer because they were unable to detect the cancers, to diagnose the cancers, and to obtain treatment for cancer, and therefore there was a stage progression. So there's a lot of questions that remain unasked that need to be investigated. We did look at the Ontario Cancer Registry did provide excess all-cause mortality. And we see that even before vaccination, there was a 4.5% increase in 2020. That's the only year that we actually have access to. And that actually some of the greatest cause of death, there's a death spike during that first lockdown. So as we see care being withdrawn from cancer patients and moved over to acute care wards where the wards remained largely empty over the COVID period, we see a spike in excess death of about 10% in April 2020. This on this side here is excess all-cause mortality data from Denis Rancourt in the general population. And one of the things that we see here is there's a spike in death for the first lockdown, and we see that appearing in the cancer data. I don't actually have the data for 2021, but again, he has excess death spikes for the first booster and the second booster, and we see that among the cancer populations. You have excess death spikes during the rollout of the boosters in early 2021. Again, why this matters, in Ontario, you are to receive equitable access to services under the law, both Canadian and Ontario law. And basically, it should be based on need and availability of treatment. And so you can see as we look through the guidelines for public health that this was reiterated a number of times that they needed to prioritize people according to need and availability of treatment. And what we see here is cancer services being suspended in order to prepare for potential COVID-19 patients. And so when you see something like this, you have to ask yourself, was this ethical and was this legal? In addition to the implementation, and aside from the vaccine, if cancer is more deadly, why are we suspending care for cancer patients and moving it to acute care wards? And so one of the things that we were able to do is support a fantastic group of people in Alberta to do an audit of the public health or the public health response for COVID-19 in Alberta. And one of the, I guess, the executives in the Alberta Health Services, which is the group that manages healthcare for the entire province, Deb Gordon testified in court and provided the outcomes for the suspension of care in Alberta. So we don't have data for Ontario, but we do have this data. And during the first wave, basically, they based their projections for what they expected to have for peak waves of COVID, which is the red. They were expecting about 2,000 patients, acute care or hospitalized COVID-19 patients, and then also about 250 ICU admittances for COVID during that period. And what we saw was even less than 1% of that. And so what we learned immediately, or what we should have learned immediately after that first wave, is that our ability to predict COVID is off terribly. They were using Chinese data, Chinese estimates, and that we should have gone back and looked at the actual World Health Organization estimates, which was less than 1% of patients would die from COVID. And so we knew that we were dealing with something that was a lot less severe. And although they adjusted their surveillance data and their projection techniques to actually Alberta data, we can see that again and again, only a fraction of the beds that were actually put aside for COVID-19 were actually used. So here we have real cancer patients who were to receive care based on need and availability of treatment. And we removed those resources and then we sent them over to acute care wards where the evidence is that the beds remained largely empty. And so I think that this is probably one of the greatest public health, or I guess health rights violations that I've seen that's extremely well documented. So that's the dip in 2020 was where we did the deep dive and we realized just how extensive the damage to the cancer care system was based on these suspensions that were to preserve healthcare capacity. But basically what that means is that it was to allow for healthcare capacity for potential COVID-19 patients that never materialized. So there's been lots of talk to date on the vaccine. And, from a developmental point of view, this is how we usually look at things. We look at what the standard is, even for vaccines. And then we look at how much safety data was actually accumulated and collected for the COVID-19 mRNA product. And even with a normal vaccine, what you would normally get is about 10 years of development, which would be 10 years of safety data collected in various manners and shapes, and then considered hopefully by regulators, and then allowing the drug to be approved. And then what we see in the COVID-19 era, and this is probably not surprising to anybody, that we had this warp speed development of what was purportedly a vaccine, but is by all definitions, including the FDA and the EMA, a gene therapy. Now, interestingly enough, the reason why it was allowed to be developed as a vaccine is because of a declaration made in 2005, we learned from the World Health Organization. And its designation as a vaccine allowed it to circumvent the regulatory controls that are normally put in place for gene therapy, which would look at structure and concentration and biodistribution and the protein products, et cetera. So all of the extensive testing that would have normally been done for gene therapy was averted because of the designation as a COVID-19 vaccine, or as a vaccine. So one of the things that we did note also is that the emergency use authorization for the COVID-19 vaccine didn't require the normal safety assessments to be done, the preclinical safety assessments, and particularly genotoxicity and oncotoxicity. And so what we're starting to see now are studies, just like the Korean study referred to earlier by Dr. Makis, where we see a statistically significant, a strong statistically significant increase in cancer rates among the vaccinated versus the unvaccinated. And so we have data that's administrative showing an increase in female cancers. We have data showing that there's new cancers on the rise. And then we have this data that is an integrated analysis looking at vaccination as one of the factors that could be linked to the increase in cancers, proving to be statistically significant. And so what we're doing at this stage is not only are we collecting updated data on administrative and registry data as it becomes available, but we're also going to be undertaking an integrated analysis and try and reproduce these findings in Ontario with the 16 million people that we have access to. And so we're happy to report that we've just received approval for that, and we're going to be moving forward with a study that will reproduce these findings, hopefully. And so I think the big message that we have, and the title of our campaign is "We Can Do Better," is a lot of all of this comes from the way in which we managed our public health crisis. And so we did this centralized siloed decision making, which we know doesn't work in medicine. And so what we're advocating for is a move away from a single person or group, public health officials, particularly quarterbacking a pandemic response, and moving to shared decision making. And one of the main things that we saw when we audited the Alberta Task Force group was that they only monitored cases. So the only thing that they were looking at is effectiveness, and they actually did not look at safety of the interventions at all. And so with a shared care model, what we would need to do is we'd need to be monitoring all aspects of an intervention moving forward. And we'd also have to have more minds in play in the decision-making process than just, a single centralized figure far, far off in the nether at the World Health Organization, directing the COVID-19 response right down to the bottom. So again, what we're looking to do at this stage is to raise awareness. And so this material, we have a video that we've prepared, which is the We Can Do Better video, and it walks through a lot of the data that I've presented today. We have a one-pager that explains, I guess, the health violation that occurred for cancer patients during the COVID period, as well as extensive documentation. And we're really looking forward to being able to present our updated findings as they become available. So thanks for giving me the time to share our research with you. And that's all I have.